Let's talk about management of acute AUB, assessment of patients. If they have an acute episode, it's an episode of heavy bleeding requiring immediate intervention to prevent further blood loss. Um, Chronic AUB is defined as AUB present for the past 6 months. We should assess these patients for signs and symptoms of hypovolemia and potential hemodynamic instability, and establish IV access with either single or two large bore IVs. Etiologies of acute AUB, obviously the pump Cohen, and then we can ask them about their medical history. 15% of patients can have Willebrand's disease. Up to 20% have some type of underlying coagulation disease. We can screen patients using these questions. If they have heavy menstrual bleeding since menarche, one of the following: postpartum hemorrhage, surgery-related bleeding, or bleeding during dental work. Or if they have two of the following: bruising 1 to 2 times a month, epistaxis 1 to 2 times a month, gum bleeding, or family history of bleeding disorders. They could have other systemic diseases such as leukemia, liver function failure, taking anticoagulation agents. We should do an exam on them to make sure there's no other source of vaginal bleeding. For labs, we should get a CBC, type and screen, pregnancy test, PT-PTT, TSH, liver function test. If we suspect von Willebrand's disease, then we need to order von Willebrand factor antigen, less than 30% consistent with the disease, platelet dependent von Willebrand factor activity, or aka von Willebrand factor ristocetin cofactor activity. If less than 30% activity consistent with the disease, factor A activity, it can be normal if the patient has, or low normal range if the patient has mild von Willebrand's disease. Endometrial sampling should be done even in patients less than 45 years old if they have a history of unopposed estrogen exposure. These patients include patients who are obese, if they have PCOS, or if the bleeding is persistent. Ultrasound should be considered as well. Treatment, medical management, IV conjugated equine estrogen can stop bleeding in 70% of patients within 8 hours. We can give Premarin 25 milligrams IV Q4 times 24 hours. Contraindications: a patient has breast cancer, active or past VTE, or liver dysfunction. Patient with hypertension, diabetes, SLE, or smoking can still be treated with estrogen for short periods of time, less than 4 weeks. OCP, or medroxyprogesterone acetate. OCP can stop bleeding in 3 days in 90% of patients. They should be on 35 microgram of ethanol estradiol TID times 7 days. Or we can give Provera. It stops bleeding in 80% of patients in 3 days. Also TID 20 milligram PO TID times 7 days. Provera or progesterone is more effective in patients with thickened endometrium. It inhibits further growth and allow withdrawal bleeding. It's not effective if the patient has denuded endometrium. Antifibrinolytic prevent fibrin breakdown, reduce bleeding in 50% of patients given either PO or IV. Intrauterine tamponade with 26 French Foley catheter and 30 cc saline solution. If they have von Willebrand disease, we can give desmopressin. This can cause fluid retention and hyponatremia. Other things we can give: recombinant factor 8 or von Willebrand factor. Avoid NSAIDs and bleeding disorders due to effects on platelet aggregation. Surgical management, DNC alone is inadequate tool for evaluation of uterine disorder. It's only temporary reduction in bleeding cycles after DNC will not be improved. However, a patient who is hemodynamically unstable, DNC can stop the bleeding within the hour. DNC with hysteroscopy may be more valuable if intrauterine pathology is suspected or tissue sampling is desired. Endometrial ablation can be done if there's no plans for future pregnancy and cancer has been reliably ruled out. UAE, of course, hysterectomy if not responding to medical management.